Let's start with the basics. The right lung, known as pulmodexter, has three lobes: the superior lobe, the middle lobe, and the inferior lobe. These lobes are separated by fissures. The horizontal fissure is a small interlobar fissure between the superior and middle lobes, while the oblique fissure is a larger interlobar fissure between the middle and inferior lobes.
And what about the left lung?
The left lung, or pulmosinister, has two lobes, the superior lobe and the inferior lobe. It also features a unique projection called the lingula, which is a tongue-like extension of the lung that corresponds to the middle lobe in the right lung. The left lung also has an oblique fissure separating its two lobes.
What about the segments within the lungs?
The lobes are further divided into smaller functional units called segments. These segments are not separated by interlobar fissures, but by fibrous septa. The right lung typically has 10 segments. The superior lobe has 3 segments: apical, posterior, and anterior. The middle lobe has 2 segments: lateral and medial. The inferior lobe has 5 segments: superior basal, also called apical, medial basal, also called cardiac, anterior basal, lateral basal, and posterior basal.
How are the segments in the left lung organized?
In the left lung, some segments merge into single functional units, resulting in a total of 8 segments. The superior lobe includes the apico-posterior, anterior, superior lingular, and inferior lingular segments. The inferior lobe consists of the superior basal, medial basal, anterior basal, lateral basal, and posterior basal segments.
Why is it important to know the segmental arrangement of the lungs?
Understanding the segmental arrangement is crucial for several reasons. When planning lung resections, which involve removing diseased lung tissue, surgeons need to know the precise layout to preserve as much healthy tissue as possible. It's also essential for bronchoscopy, a procedure to explore the inner parts of the airways and detect abnormalities like foreign bodies or tumors. Additionally, precise localization of tumors relies on this detailed anatomical knowledge.
How are these segments supplied with blood and air?
Each lung segment is supplied by its own segmental bronchus and a segmental pulmonary artery. This ensures that each segment can function somewhat independently. However, the pulmonary veins do not strictly follow this segmental pattern and tend to run in a different direction. The segments are conical in shape, with the apex pointing towards the hilum, the central part of the lung where the bronchus, arteries, and veins enter and exit.
What about the lymphatic drainage and overall structure within a segment?
At the center of each segment, you'll find the bronchus, a branch of the pulmonary artery, a branch of the bronchial artery, which supplies nutrients, and the central lymphatic drainage. The periphery of each segment is surrounded by a fibrous septum, and around the septum, you'll find branches of the pulmonary veins and peripheral lymphatic drainage.
This is incredibly detailed. Why is this level of detail necessary?
This detailed understanding is crucial for accurately diagnosing and treating various lung conditions. For instance, during a bronchoscopy or surgical procedure, knowing the precise anatomy helps avoid complications and ensures the best outcomes for patients.
Could you explain the different parts of the lungs?
Certainly. Let's break it down. The apex of the lung, or apex pulmonis, is the topmost part. The lung surface facing the mediastinum, called the facies pulmonalis, is where the lung connects to the mediastinum via the hilum. The hilum is an essential area as it includes the bronchus, pulmonary arteries, pulmonary veins, bronchial arteries, nerves, lymphatic vessels, and nodes. Interestingly, on the right side, the bronchus is situated highest, whereas on the left side, the pulmonary artery is the highest structure.
What are the other surfaces of the lung?
The facies costalis is the largest surface, and it lies adjacent to the ribs. Then we have the facies diaphragmatica, which is the surface that rests on the diaphragm. The base of the lung, or basis pulmonis, is close to the diaphragm as well.
Are there any variations in lung structure?
Yes, the lungs can exhibit certain variations. For instance, a tracheal bronchus, which is rare in humans, supplies the upper lobe of either the right or left lung and originates directly from the trachea. This is common in some mammals, like domestic pigs. There's also accessory lobarization, where a part of the lung is separated by its interlobar fissure. Examples include the lingular lobe of the left lung and the azygous lobe on the mediastinal surface of the right lung.
What about pulmonary sequestration?
Pulmonary sequestration is a condition where lung tissue is not connected to the pulmonary circulation and is instead supplied by the bronchial artery. This means the sequestered lung tissue receives blood differently than the rest of the lung.
How is lung tissue functionally organized?
On a finer level, lung tissue is divided into smaller units. We differentiate between 15 orders of bronchial branches and 5 orders of bronchioles. Bronchioles form functional units known as secondary lobules, which consist of 3 to 5 terminal bronchioles. A terminal bronchiole is the last airway branch that does not contain alveoli. Each primary lobule is supplied by one terminal bronchiole, leading to the acinus, which includes 3 orders of respiratory bronchioles and alveoli within their walls. This continues to alveolar ducts and finally to alveolar sacs containing several alveoli.
Can you explain secondary lobules in more detail?
Sure. The term secondary lobule comes from radiology. These structures, about 1 to 1.5 centimeters in size, are the smallest units visible on a radiograph. They have a fibrous boundary and are supplied by 3 to 5 terminal bronchioles. Each secondary lobule contains smaller units called acini, separated by interlobular septa, which also carry the pulmonary veins and lymphatic vessels. Within the lobule, intralobular septa separate individual acini. These septa can show characteristic changes in various pathological conditions visible on CT or X-ray images, such as interstitial pulmonary edema, alveolar pulmonary edema, interstitial pulmonary fibrosis, and lung inflammations like COVID-19.
How does blood flow within the lungs?
Deoxygenated blood flows into the lung tissue, where it reaches the alveoli for oxygenation. This oxygenated blood then flows laterally and outward. Deoxygenated blood moves along the axis of the secondary lobule, while oxygenated blood flows outwards along the periphery. The bronchial artery branches along the bronchi, providing additional blood supply.
What about the pulmonary interstitium?
The pulmonary interstitium is the tissue that forms the framework of the lung. It runs alongside central branching structures within acini and on their surfaces along with veins and lymphatic drainage. Interstitial lung processes can affect these areas and are critical for maintaining the structural integrity of the lungs.
Thank you, Emma, for the detailed explanation.
You're welcome. Understanding these details is vital for diagnosing and treating various lung conditions effectively.
Hi, Emma. Can you explain the blood supply to the lungs?
Of course. The blood supply to the lungs, known as vasa pulmonum, consists of 3 main types of blood vessels: the pulmonary arteries A, pulmonalis, the pulmonary veins versus pulmonales, and the bronchial arteries AA bronchioles.
What is the role of the pulmonary arteries?
The pulmonary arteries are crucial as they carry deoxygenated blood from the right ventricle of the heart to the lungs. They branch into 2 main arteries, which then divide alongside the bronchi into segmental branches. This branching continues to follow the bronchial tree down to smaller segments. The primary function of the pulmonary arteries is to transport blood low in oxygen and high in carbon dioxide to the lungs for gas exchange.
How does the blood get back to the heart?
That's where the pulmonary veins come in. These veins carry oxygenated blood from the lungs back to the left atrium of the heart. Unlike the arteries, the veins don't follow the same segmental organization. Instead, they gather into several large trunks and travel almost perpendicularly to the arteries. Interestingly, the walls of the pulmonary veins contain myocardial cells, which can sometimes be a source of arrhythmias.
And what about the bronchial arteries?
The bronchial arteries are part of the nutritional circulation. They originate from the aorta and the intercostal arteries, and their primary role is to supply the lung tissues, including the alveoli, interstitium, and bronchial walls, with nutrients and oxygen. Under normal conditions, these arteries are quite thin, but in cases of chronic lung diseases, they can hypertrophy or enlarge to meet the increased demand.
How do these vessels interact within the lungs?
The pulmonary arteries and veins have distinct paths. The arteries closely follow the segmental structure of the lungs and branch along with the bronchi. In each lung segment, the arteries are centrally located. In contrast, the pulmonary veins are more peripheral and don't adhere to the segmental arrangement. They course through the periphery of each segment, eventually converging towards the heart.
That makes sense. So, the arteries and veins serve different purposes and have unique pathways within the lungs.
Exactly. The pulmonary arteries and veins work together to facilitate gas exchange, arteries bringing deoxygenated blood to the lungs, and veins returning oxygenated blood to the heart. Meanwhile, the bronchial arteries ensure the lung tissues themselves receive adequate nourishment. This efficient organization supports the lung's vital role in respiration.
Thank you for the detailed explanation. It's fascinating how the body has such a complex yet well-organized system.
You're welcome. Understanding the blood supply to the lungs is fundamental to grasping how our respiratory system functions, especially in both health and disease.
Can you explain the functional circulation of the lungs?
Absolutely. The functional circulation of the lungs primarily involves the pulmonary artery A, pulmonalis, which originates from the right ventricle of the heart. This artery branches into two main arteries, known as the left and right branches ramus sinister et dexter, entering the lungs at the pulmonary hilum. It carries deoxygenated blood with low oxygen content and high carbon dioxide content to the lungs.
How does this branching continue within the lungs?
Great question. Within the lungs, the pulmonary artery further divides into lobar branches rami lobers. On the left side, it splits into upper and lower branches, while on the right side, it splits into upper, middle, and lower branches. These lobar branches then divide into segmental branches rami segmentals, with 10 segmental branches on each side of the lungs.
What happens after the segmental branches?
The segmental branches further subdivide into subsegmental branches rami subsegmentaires and then into lobular branches rami lobulars, which direct blood into the secondary lobules of the lungs. This is where the capillary network rete capillare plays a crucial role. The capillaries surround the alveoli, facilitating the exchange of gases. Deoxygenated blood releases carbon dioxide and absorbs oxygen in this network.
So, the blood gets oxygenated in the capillary network?
Exactly. Once the blood is oxygenated, it flows from the capillaries into the interlobular septum and then collects into the pulmonary veins V, pulmonalis, which return the oxygenated blood to the left atrium of the heart from the dorsal side.
What about the nutritional circulation of the lungs?
The nutritional circulation is handled by the bronchial arteries A, bronchialis. These arteries usually originate from the aorta, with variable origins and numbers of branches. Typically, there are two bronchial arteries, one on each side. On the right, they often branch from the third posterior intercostal artery, while on the left, they directly branch from the thoracic aorta. These arteries supply oxygen and nutrients to the lung tissues. In chronic lung diseases, the bronchial arteries can hypertrophy or enlarge, often leading to bleeding into the lungs, known as hemoptysis.
And how is the blood drained from the bronchial circulation?
The blood from the bronchial circulation is drained by the bronchial veins versus bronchioles. These veins drain into the azygous vein, accessory hemiazygos vein, intercostal veins, and ultimately into the superior vena cava.
Can you describe the secondary lobule structure?
Certainly. A secondary lobule typically contains 3 to 5 terminal bronchioles and is surrounded by the interlobular septum. The pulmonary vein and lymphatic pathways run within the septum. Deoxygenated blood flows through the center of the secondary lobule, while oxygenated blood drains outward along its periphery.
What is the pulmonary hilum, and why is it important?
The pulmonary hilum is a vital structure that connects the lungs to the mediastinum. It contains several important components: the bronchi, branches of the pulmonary artery carrying deoxygenated blood, pulmonary veins carrying oxygenated blood, the bronchial arteries for nutritional supply, nerves, lymphatic vessels, and lymph nodes. The arrangement within the hilum can vary. On the right side, the bronchus is positioned highest, and the pulmonary veins are lowest. On the left side, the pulmonary artery is highest, with the bronchus positioned below it, and the pulmonary veins are lowest.
This makes the pulmonary hilum quite a complex structure.
Indeed, it is. The pulmonary hilum plays a critical role in organizing the passage of air, blood, and nutrients into and out of the lungs, ensuring efficient respiratory and circulatory function.
Thank you for the detailed explanation. It's incredible how intricately organized our lungs are.
You're welcome. The complexity and efficiency of lung circulation are key to our ability to breathe and oxygenate our blood effectively. Understanding these mechanisms is fundamental for anyone studying respiratory physiology or medicine.
Hello, Emma. Can you explain the branching of the airways from the trachea to the alveoli?
Of course. Let's start with the trachea, also known as the windpipe. The trachea is a tube that connects to the larynx and is situated between the C6 and Th4 vertebrae. It attaches to the cricoid cartilage via the cricotracheal ligament.
What is the structure of the trachea like?
The trachea is formed by tracheal cartilages, which are cartilaginous and horseshoe-shaped structures providing a firm and elastic framework. These cartilages are linked by annular ligaments. The back part of the trachea, called the membranous wall, is made of connective tissue, and beneath it lies the trachealis muscle, a smooth muscle that regulates the diameter of the trachea under the influence of the parasympathetic and sympathetic nervous systems. In front of the trachea is the pretracheal fascia, which transitions to form the adventitia, a loosely structured fibrous membrane.
What can you tell me about the inside of the trachea?
Inside the trachea, you'll find vertical folds of mucous membrane called plesiverticals. The walls contain elastic fibers that anchor the mucosa to the cartilage and extend through the muscular layer dorsally. There are also multiple tracheal glands located under the mucosa. The entire respiratory tract is lined with ciliated epithelium, which helps move mucus and trapped particles out of the airways.
What happens after the trachea?
The trachea divides at the level of the Th4 vertebra into the right and left main bronchi, creating a ridge called the carina, which is visible during endoscopy. This branching structure is known as the bronchial tree. The main bronchi, also called bronchi principalis, branch at an angle between 70 to 90 degrees.
Is there any difference between the right and left main bronchi?
Yes, there are significant differences. The right main bronchus branches at about 30 degrees from the vertical line of the trachea and is shorter, wider, and more vertical compared to the left bronchus. This is why inhaled foreign objects are more likely to enter the right bronchus. In contrast, the left main bronchus branches at about 60 degrees, making it longer, narrower, and more curved.
What happens after the main bronchi enter the lungs?
Upon entering the lungs at the hilum, the main bronchi divide dichotomously, meaning each bronchus splits into two. This forms the lobar bronchi. The right lung has 3 lobar bronchi, the superior, middle, and inferior lobar bronchi. The middle and inferior lobes are served by the intermediate bronchus. The left lung has 2 lobar bronchi, the superior and inferior lobar bronchi.
How do the bronchi continue to branch?
The lobar bronchi further divide into segmental bronchi, with each lung having 10 segmental bronchi that supply specific lung segments. For example, the right upper lobe has 3 segments, apical, dorsal, and anterior. The bronchi continue to branch multiple times, around 18 to 20 times, becoming progressively smaller.
What are these smaller bronchi called?
The smaller branches are called subsegmental bronchi, which further divide into even smaller branches known as lobular bronchi. Each of these branches continues to split until they reach the alveoli, where gas exchange occurs.
Thank you for explaining the branching of the airways from the trachea to the alveoli.
You're welcome. Understanding the structure and branching of the airways is fundamental for comprehending how air reaches the alveoli, where oxygen is exchanged for carbon dioxide in our blood.
Can you explain the structure and branching of the bronchi?
Certainly. Let's begin with the wall of the bronchi. The bronchi have 3 main layers: the mucosa, the muscular layer, and the fibrocartilaginous layer.
What can you tell me about the mucosa?
The mucosa is lined with ciliated columnar epithelium and contains glands and lymphatic follicles. These cilia help move mucus and trapped particles out of the airways, keeping them clear.
How about the muscular layer?
The muscular layer is situated in the middle and plays a crucial role in regulating the diameter of the bronchi. This smooth muscle layer contracts and is influenced by both the parasympathetic and sympathetic nervous systems. Parasympathetic stimulation causes bronchoconstriction, narrowing the airways, while sympathetic activation leads to bronchodilation, widening the airways. The regulation is most significant in bronchi smaller than 1 millimeter in diameter.
What about the fibrocartilaginous layer?
The fibrocartilaginous layer is the outermost layer. In larger bronchi, such as those at the segmental level, it consists of cartilage arches similar to those in the trachea. In bronchi larger than 1 millimeter, it has supportive plates within the branching structure. In bronchi smaller than 1 millimeter, cartilage is absent, and the wall is composed only of the muscular layer and connective tissue.
What is the terminal branching of the bronchi like?
The terminal bronchioles are the smallest branches of the bronchi, with a diameter of about 1 millimeter. The terminal bronchioles are even smaller, at 0.5 millimeters in diameter. They consist only of a muscular layer that forms a spiral band. These are the last of the typical bronchioles, lined with ciliated epithelium that transitions to cuboidal epithelium in the periphery and lack bronchial glands and goblet cells.
What comes after the terminal bronchioles?
Beyond the terminal bronchioles, we enter the respiratory zone, starting with the acinus. Each acinus corresponds to one terminal bronchiole and contains 3 orders of respiratory bronchioles. These respiratory bronchioles have alveoli in their walls where gas exchange begins. The acini are separated by intralobular septa.
What are the respiratory bronchioles?
From each terminal bronchiole, 2 respiratory bronchioles arise. These short tubes contain collagen and elastic fibers along with smooth muscle cells in their middle layer. Alveoli are already present in their walls, marking the beginning of the gas exchange process.
What about the ductus alveolaris?
The respiratory bronchioles branch into 2 to 10 alveolar ducts, called ductili alveolars. These ducts have increasing numbers of alveoli in their walls as they progress and are lined with flat epithelium. They eventually end in a structure called an atrium.
Can you explain the atrium?
The atrium is a short passageway that marks the end of the terminal bronchioles. It's the last part where muscle fibers are present, and it transitions into the alveolar sacs, or saculi alveolars.
What are the saculi alveolars?
The saculi alveolars are clusters of alveoli, with about 10 alveoli per sacculus. These alveoli are spherical outpouchings where gas exchange occurs. In humans, there are approximately 300 to 400 million alveoli, providing a total respiratory surface area of about 80 square meters.
How do the alveoli function in gas exchange?
The alveoli have thin walls lined with a single layer of flat epithelium, which facilitates the diffusion of gases. Oxygen passes from the alveoli into the blood in the capillaries, and carbon dioxide moves from the blood into the alveoli to be exhaled. This exchange occurs across a double layer, the alveolar epithelium and the capillary endothelium.
Are there any special features in the alveoli?
Yes, the alveoli have small openings called alveolar pores or pores of Kohn. These pores connect adjacent alveoli, allowing for pressure equalization and collateral airflow, which is especially useful if a bronchiole is blocked. However, they can also facilitate the spread of infections between alveoli.
This is all very detailed and fascinating. Thank you for explaining the structure and branching of the bronchi and alveoli.
You're welcome. Understanding these structures is essential for comprehending how air travels through the respiratory system and how gas exchange occurs in the lungs.
Hello, Emma. Can you explain the coronary arteries to me?
Sure. Let's start with the right coronary artery. It originates from the right aortic sinus. Its pathway is relatively simple compared to the left coronary artery. The right coronary artery is thinner, and it descends around the right ventricle in the coronary sinus, moving dorsally and downward. At the crux of the heart, it branches into the posterior interventricular artery, which runs in the posterior interventricular sulcus.
What does the right coronary artery supply?
The right coronary artery supplies the right atrium, part of the left atrium near the septum, the wall of the right ventricle, all papillary muscles of both ventricles, and the interventricular septum. It has several branches. Rami coni arteriosi. These supply the pulmonary conus and the anterior walls of the right ventricle. Ramus ventricularis dexter. RVD. This is a branch for the right ventricle. Ramus marginalis dexter, RMD, found along the inferior margin. Rami atrials dextri. These supply the right atrium, including the main right atrial artery, which gives off the branch for the sinoatrial node. The artery continues as the posterior interventricular artery, RIVP, which supplies part of the left ventricle, especially the septal and apical regions. It also branches into the ramus posterolateralis's dexter, RPLD, supplying the lower part of the left ventricle and gives off the ramus nodi atrioventricularis.
What about the left coronary artery?
The left coronary artery originates from the left aortic sinus. It supplies the wall of the left atrium, the left ventricle, part of the right atrium, the papillary muscles of both atria, and the interatrial and interventricular septum. Shortly after its origin, it divides into two main branches. Ramus interventricularis anterior, RI or LAD. This runs in the anterior interventricular sulcus towards the apex of the heart. It has diagonal branches, Rami diagonals, that supply the anterior wall of the left ventricle, and septal branches, ramus septalis, that go into the septum. Ramus circumflexus, RCX. This bends around the left side and runs in the coronary sinus in front of the left ventricle. It has marginal branches, Rami marginalis, such as the ramus marginalis sinister, RMS1, RMS3, which often supply the lateral wall of the left ventricle, and the terminal branch ramus posterolateralis's sinister, supplying the lower wall of the left ventricle.
Can you explain the dominance of coronary arteries?
Sure. Coronary artery dominance refers to which coronary artery supplies the posterior descending artery, PDA, and the posterolateral branches. There are three types. Right dominance. The PDA and the majority of the posterolateral branches are supplied by the right coronary artery. This is the most common type. Balanced dominance. The PDA is supplied by the right coronary artery, and the posterolateral branches are equally divided between the right and left coronary arteries. Left dominance. The PDA and the majority of the posterolateral branches are supplied by the left coronary artery.
What happens if there is stenosis in the coronary arteries?
Stenosis, or narrowing, of a coronary artery can severely impact blood flow to the heart muscle. For instance, stenosis in the artery supplying the AV node can lead to rhythm disturbances due to inadequate blood supply. Additionally, if the His bundle is affected, it can cause conduction system issues. When stenosis occurs, the perfusion of the right ventricle and the lower part of the left ventricle can be compromised.
How do we visualize the coronary arteries?
There are a couple of main methods. Catheterization coronary angiography. This involves a standardized projection to visualize the coronary arteries. CT angiography. This provides a 3D visualization of the coronary arteries, giving a detailed view of the coronary anatomy.
What about the nutritional areas of the heart?
The American Heart Association, AHA, describes the myocardium of the left ventricle in a segmental arrangement, dividing it into territories or segments. The left ventricle is divided into 3 sections, with the apex being the 17th segment. By assessing these territories through echocardiography, CT, MRI, or myocardial perfusion imaging, we can quantify the extent of any damage or disease. These territories also help in evaluating the morphology of the affected coronary arteries. For example, the lower and bottom part of the septum is supplied by the right coronary artery. The upper part of the septum and the anterior wall is supplied by the ramus interventricularis anterior. The lateral part is supplied by the ramus circumflexus. This structured approach allows for precise assessment and treatment planning based on the specific regions affected.
Hello, Emma. Can you explain the veins of the heart to me?
Of course. The veins of the heart, known as venae cordis, drain blood from the myocardium. They are quite similar to the coronary arteries in terms of their course, and they follow a similar path. However, heart veins don't have valves along their path.
How are these veins classified?
The heart veins are classified into 3 main groups based on where they drain. 1. Veins draining into the coronary sinus. These carry about 60% of the heart's blood. 2. Anterior veins of the right ventricle. Venae ventriculi dextri anteriors. These carry about 34% of the blood. 3. Small cardiac veins, veni cordis minime, these carry about 6% of the blood.
What can you tell me about the coronary sinus?
The coronary sinus is a wide venous channel and the main collection vessel for blood returning from the myocardium. It is located in the left coronary sulcus and drains into the right atrium. At its opening, there is a valve called the valvula sinus coronarii. The coronary sinus collects blood from several major veins. 1. Great cardiac vein, vena cordis magna. It begins as the anterior interventricular vein at the apex of the heart, travels in the anterior interventricular sulcus, collects blood from the left ventricle, and continues as the great cardiac vein. It then runs to the back of the heart and drains into the coronary sinus. 2. Middle cardiac vein, vena cordis media. It starts at the apex of the heart, travels in the posterior interventricular sulcus, and drains into the coronary sinus before it opens into the right atrium. 3. Small cardiac vein, vena cordis parva. It starts along the inferior margin of the right ventricle as the marginal vein, runs in the right coronary sulcus between the right atrium and ventricle, and drains into the coronary sinus.
What about the veins of the right ventricle and the smallest cardiac veins?
The anterior veins of the right ventricle, veni ventriculi dextri anteriors, are 2 to 4 veins on the front side of the right ventricle. They run from the apex towards the coronary sulcus and drain directly into the right atrium independently. They do not follow a common path with other veins and can sometimes drain into the small cardiac vein. The small cardiac veins, veni cordis minime or Thebesian veins, are tiny veins that drain directly into the nearest heart chambers. They are more numerous in the atria but can also be found in the ventricles, especially at the apical part of the septum. These veins account for up to 40% of the blood returning from the coronary circulation, along with the anterior veins of the right ventricle.
Why is the coronary sinus important?
The coronary sinus is crucial because it sometimes serves as an additional entry point for the left superior vena cava if the right superior vena cava is absent. This anatomical variation allows blood to enter the heart. Additionally, the coronary sinus is used in medical procedures such as the insertion of pacemaker electrodes, which can be threaded through the coronary sinus to reach the left ventricle and the outflow tract.
Can you summarize the main heart veins and their locations?
Certainly. Here's a quick summary. 1. Anterior interventricular vein, V. Interventricularis anterior, runs in the anterior interventricular sulcus. 2. Great cardiac vein, V. Cordis magna, runs in the anterior interventricular sulcus and then in the left coronary sulcus. 3. Coronary sinus, located in the left coronary sulcus, draining into the right atrium. 4. Middle cardiac vein, V. Cordis media, runs in the posterior interventricular sulcus. 5. Small cardiac vein, V. Cordis parva, runs in the right coronary sulcus. 6. Anterior veins of the right ventricle, versus anteriors ventriculi dextri, drain directly into the right atrium. 7. Smallest cardiac veins, versus minime or Thebesian veins, drain directly into the nearest heart chamber. These veins all play vital roles in draining deoxygenated blood from the myocardium back into the heart for reoxygenation.
Hi, Emma. Could you explain the heart's conduction system?
Of course. The heart's conduction system is crucial for understanding heart rhythm disorders. It's made of specialized myocardium, which is insulated from the rest of the working myocardium. This system is specialized in signal transmission.
How do these cells work?
The cells of the conduction system have the ability for spontaneous diastolic depolarization of their cytoplasmic membranes. This change in the membrane generates an action potential, which spreads from cell to cell at communication contact points. The timing of these electrical activities can be recorded by an electrocardiograph, producing a curve known as an electrocardiogram or ECG.
What influences the speed and frequency of these signals?
The speed of conduction and the frequency of impulses are increased by sympathetic stimulation and decreased by parasympathetic stimulation.
What about the nodes involved in this system?
There are 2 main nodes. The first is the sinoatrial node, or SA node, which is the primary pacemaker of the heart. It's located at the opening of the superior vena cava on the crista terminalis, a ridge that separates the sinus venosus from the main atrial chamber. This node generates signals at a rate of 60 to 80 impulses per minute, known as the sinus rhythm. The frequency can increase or decrease depending on factors like physical exertion and temperature.
How do the impulses travel from the SA node?
The impulses spread from the SA node to the atrioventricular node, or AV node, primarily through the internodal pathways. These pathways consist of closely packed cardiomyocytes in the right atrium, facilitating the transmission of the impulse between the SA and AV nodes and between the right and left atria.
What is the role of the AV node?
The AV node acts as the secondary pacemaker. It's located at the apex of Koch's triangle, near the opening of the coronary sinus, just below the fossa ovalis. Here, the impulse transmission slows down, with a frequency of 40 to 50 beats per minute. If the primary pacemaker fails or there's uncoordinated impulse transmission, the AV node takes over, creating a slower rhythm called nodal rhythm.
What happens next in the conduction pathway?
From the AV node, the signal moves to the atrioventricular bundle, also known as the His bundle. This bundle passes through the right fibrous triangle of the heart skeleton, splitting into the right and left bundle branches or Tawara branches. The right bundle branch is a direct continuation of the His bundle, consisting of working myocardial cells and fewer Purkinje fibers, while the left branch forms a fan-like structure composed mainly of Purkinje fibers.
Can you tell me more about Purkinje fibers?
Purkinje fibers run subendocardially within the muscle layer just beneath the endocardium. Jan Purkine discovered this conduction system. These fibers ensure synchronized contraction of the myocardial cells by transmitting impulses efficiently. The conduction system is designed for one-way signal transmission due to the connective tissue surrounding the fibers, providing insulation from the rest of the myocardium.
How do nerves influence heart function?
The heart is innervated by the autonomic nervous system, but it can function independently due to the myocardium's inherent activity. Parasympathetic activity decreases heart rate and contraction strength, causing coronary artery constriction. Signals are transmitted to the heart via the vagus nerve, with branches running along the carotid artery to the aortic arch. Excessive vagus nerve stimulation, especially in individuals with narrowed coronary arteries, can lead to vagal death.
And the sympathetic nervous system?
The sympathetic nervous system increases heart rate and contraction strength, dilating coronary arteries through circular muscle fibers. There are 3 levels of cardiac nerves: superior cardiac nerve from the superior cervical ganglion, middle cardiac nerve from the middle cervical ganglion, and inferior cardiac nerve from the cervicothoracic ganglion, stellate ganglion. Pain from myocardial ischemia is often referred to the T1, T4 dermatomes, causing pain on the ulnar side of the forearm and hand.
What about the pericardium?
The pericardium receives innervation from the phrenic nerve, which runs anterior to the lung hilum. Its main root supply is from C4, which can cause pain that radiates to the lower extremity.
Thank you for the detailed explanation.
You're welcome. Understanding the heart's conduction system is fundamental in diagnosing and managing cardiac conditions.
Hello, Emma. Could you explain the structure and function of heart valves?
Absolutely. Heart valves, or valvae cordis, play a crucial role in ensuring one-way blood flow through the heart chambers. Let's dive into their anatomy and function. Heart valves consist of fibrous leaflets covered by endocardium, attaching to the fibrous rings of the heart skeleton. They are stronger in the atria than in the ventricles, particularly robust in the left side of the heart.
How do atrioventricular valves differ from semilunar valves?
Atrioventricular valves, found between the atria and ventricles, prevent blood backflow into the atria during ventricular contraction, systole. Their closure marks the first heart sound, audible due to their fibrous ring support and chordae tendineae, which anchor to papillary muscles to prevent valve inversion.
What about semilunar valves?
Semilunar valves, located at the exits of the ventricles and the great arteries, include the aortic and pulmonary valves. They consist of 3 cusps that prevent blood from flowing back into the ventricles during relaxation, diastole. Their closure produces the second heart sound.
How do these valves function mechanically?
Each semilunar cusp is reinforced internally by fibrous tissue and forms a half-moon shape that ensures tight closure against the vessel walls. They open when ventricular pressure exceeds arterial pressure and close when ventricular pressure drops post-contraction.
Could you explain the differences between the tricuspid and mitral valves?
The tricuspid valve, between the right atrium and right ventricle, has 3 leaflets, anterior, septal, posterior, while the mitral valve, between the left atrium and left ventricle, has 2, anterior and posterior. Both are vital in maintaining unidirectional blood flow through the heart.
Are there any clinical implications related to heart valves?
Indeed, conditions like valvular stenosis or regurgitation can occur, affecting valve function. For instance, mitral valve prolapse or aortic stenosis can lead to inefficient blood flow and may require surgical intervention to repair or replace the affected valve.
What additional structures support valve function?
The heart's fibrous skeleton, composed of dense connective tissue, provides structural support for the valves and attachment points for cardiac muscle. This arrangement ensures the coordinated opening and closing of valves throughout the cardiac cycle.
Thank you for explaining that. Could you summarize the main points about heart valves?
Heart valves regulate blood flow through the heart, with atrioventricular valves preventing backflow from the ventricles to the atria and semilunar valves ensuring blood flows in one direction from the ventricles to the arteries. Their proper function is essential for maintaining cardiac output and overall cardiovascular health.
What is the role of the heart skeleton cordis?
The heart skeleton provides essential support, ensuring the heart stays compact during its movements and experiences less mechanical strain. It consists of dense fibrous tissue and includes various fibrous rings known as annuli fibrosi.
What are these fibrous rings used for?
Each fibrous ring supports a specific heart valve, the annulus aorticus for the aortic valve, which is triple bent like a garland, the annulus fibrosus trunci pulmonalis for the pulmonary valve, the annulus fibrosus dexter for the tricuspid valve, and the annulus fibrosus sinister for the bicuspid, mitral, valve.
Could you explain the structure of the trigonum fibrosum?
Certainly. The trigonum fibrosum is a triangular fibrous area formed between these rings. The trigonum fibrosum dextrum lies between the annulus fibrosus dexter, sinister, and aorticus, providing passage for the fasciculus atrioventricularis, which facilitates the electrical impulse transmission between the atria and ventricles.
How does this affect the heart's electrical activity?
The heart's electrical insulation is crucially maintained by structures like the Tadaros tendon and the trigonum fibrosum. Tadaros tendon connects the posterior part of trigonum fibrosum dextrum to the valve of the inferior vena cava, playing a role in the electrical isolation of the atria and ventricles, ensuring synchronous electrical signal propagation.
What about the ligamentum infundibuli?
The ligamentum infundibuli is a fibrous band between the pulmonary trunk and the aorta, limiting torsional movements and ensuring proper alignment during heart contractions. It extends from the trigonum fibrosum dextrum to the annulus aorticus and annulus trunci pulmonalis.
How do the laminae fibrosi contribute to heart function?
Laminae fibrosi asterisk are fibrous plates supporting the valves and the membranous part of the septum in the atria and ventricles. They separate the myocardium of the atria and ventricles, preventing the spread of electrical impulses between these chambers.
What is the significance of the fila coronaria?
The fila coronaria, found in both the mitral and tricuspid valves, are projections embedded in the sulcal connective tissue. They play a role in anchoring these valves securely within the heart structure.
So, these structures ensure the heart functions efficiently?
Exactly. The intricate network of fibrous tissues and rings, along with specialized tendons and ligaments, forms a structural foundation that supports the valves, isolates electrical impulses, and ensures the heart's mechanical integrity and efficient function.
Hello, Emma. Can you explain the basic structure and location of the liver?
Of course. The liver is an unpaired organ that weighs about 1.5 kilograms. It's situated in the right side of the abdominal cavity, just beneath the diaphragm. The liver is connected to the biliary system, which is essential for the digestion and processing of fats. Interestingly, the left lobe of the liver extends to the left of the midline. In some cases, this extension is quite significant, reaching behind the spleen and around the stomach.
What are the firmly fused parts of the liver?
The liver has a few areas that are firmly fused. One such part is the area that closely adheres to the diaphragm, known as the bare area or area nuda. This section is not covered by the peritoneal surface, hence it is referred to as bare. Additionally, the inferior vena cava passes through the liver, creating an indentation as it presses into the liver tissue.
Could you describe the peritoneal spaces around the liver?
Certainly. The liver is surrounded by several peritoneal spaces. These include the space around the liver, the subhepatic space, and the diaphragmatic space. There are also specific areas where free abdominal cavity fluid might accumulate, such as the hepatorenal recess, located between the kidney and liver, and the subdiaphragmatic recess.
What about the ligaments associated with the liver?
The liver is supported and connected by several important ligaments. The ligamentum teres hepatis is the obliterated umbilical vein, found caudally. The ligamentum venosum is another obliterated structure, part of the embryonic venous duct connecting the portal vein and the inferior vena cava, positioned cranially on the dorsal side. On the anterior side of the liver, we have the ligamentum falciform, a remnant of the ventral mesentery. The coronary ligaments, both anterior and posterior, form a crown-like structure around the bare area, suspending the liver from the diaphragm. On the sides, the triangular ligaments converge with the coronary ligaments, creating a duplicature. Lastly, there's the fibrous appendix, an appendage at the end of the liver on the left.
How does the liver maintain its smooth surface?
The liver is covered by the peritoneum, which provides a smooth surface. This smooth covering is essential for the liver's movement and interaction with adjacent organs.
What can you tell me about the posterior part of the liver?
The posterior part of the liver bears impressions of various organs, including the stomach, kidneys, and duodenum. Because the liver is quite elastic, it retains these impressions, which helps in identifying its orientation and the lobes.
How are the lobes of the liver distinguished?
The lobes of the liver are distinguished based on certain anatomical features, particularly the sagittal fissures. The right sagittal fissure is a deep groove that houses two critical structures: the groove for the inferior vena cava, known as the sulcus venae cavi inferioris, and the fossa vesicae felii, where the gallbladder resides. These features play a vital role in the vascular connection and outflow of the liver.
And the left sagittal fissure?
The left sagittal fissure contains the ligamentum venosum aurantiae, also known as the ductus venosus, and the ligamentum teres hepatis. In cases where there's increased pressure in the portal circulation, this part can recanalize back into the umbilical vein, forming venous structures that allow blood to flow out of the liver through the umbilical vein.
Finally, what is the porta hepatis?
The porta hepatis is the gateway to the liver, located between the right and left sagittal fissures. This crucial structure contains the portal triad, the hepatic duct, the proper hepatic artery, and the portal vein. The porta hepatis leads into the hepatoduodenal ligament, which continues to the duodenum, facilitating the liver's connection to the rest of the digestive system.
Can you explain how the liver lobes are structured and separated?
Certainly. The liver is divided into several lobes that are not equal in size, but are functionally separated. Each lobe has its own distinct vascular supply and bile duct system. The left lobe, or lobus sinister, is clearly visible from both the front and back. The right lobe, or lobus dexter, is separated from the left lobe by Cantley's line. This line runs from the axis of the gallbladder fossa across the convexity of the liver to the fossa of the inferior vena cava. Additionally, the internal boundary between these lobes is formed by the middle hepatic vein.
What are the quadrate and caudate lobes?
The quadrate lobe, or lobus quadratus, is located under the transverse part formed by the portal vein. The caudate lobe, or lobus caudatus, is an elongated lobe that is visible only from the back. In cases of cirrhosis or other liver diseases, the caudate lobe tends to enlarge because it has a direct connection to the veins leading into the inferior vena cava. It often overlaps the inferior vena cava from the back.
How are the liver segments defined, and why are they important?
The liver is divided into functional anatomical units known as segments. These segments can be surgically removed under certain conditions, making them crucial for liver surgeries. The division is based on vascular supply. The horizontal plane of the portal vein divides the liver horizontally into upper and lower segments, while three vertical planes formed around the course of the hepatic veins, right, middle, and left, further subdivide it.
Can you describe the different segments within each lobe?
Certainly. The caudate lobe is located at the top and back of the liver. The left lobe, or lobus sinister, includes the superior lateral left segment, sinister lateralis superior, and the inferior medial left segment, sinister medialis inferior, divided by the left hepatic vein. The quadrate lobe includes the superior medial, medial superior, and inferior medial, medial inferior, segments. The right lobe, or lobus dexter, has several segments: anterior medial, posterior inferior, posterior lateral, and posterior medial, divided by the right hepatic vein into medial and lateral sectors.
Why is it important to differentiate these segments?
Differentiating these segments is crucial for surgical procedures. Surgeons can remove segments as functional units during operations. For example, they might perform a left-sided hepatectomy to remove a specific segment or an extended left-sided hepatectomy for a larger portion. Similarly, right-sided hepatectomies and extended right-sided hepatectomies are performed based on the extent of the disease. This method is particularly useful for removing affected areas such as metastases, allowing for precise and targeted surgeries.
Hi, Emma. Can we talk about the liver today? I'm curious about its structure and function.
Of course. The liver is an unpaired organ weighing about 1.5 kilograms. It's located in the right upper quadrant of the abdomen, just below the diaphragm. The liver is connected to the bile duct system, which plays a crucial role in digestion.
What are the main parts of the liver?
The liver consists of several parts, with the most notable being the right and left lobes. The left lobe extends to the left of the midline and sometimes reaches as far as the spleen, wrapping around the stomach. There are also smaller lobes, such as the quadrate and caudate lobes.
How are these lobes different from each other?
The lobes are not only structurally distinct but also functionally separated. They have unique vascular supplies and bile duct connections. The right and left lobes are separated by the Cantley's line, which runs through the gallbladder fossa and the inferior vena cava.
What about the peritoneal spaces around the liver?
Surrounding the liver are several peritoneal spaces, including the subhepatic space and the subdiaphragmatic space. These spaces can sometimes accumulate fluid, which can be an indication of various medical conditions.
Can you explain the significance of the ligaments associated with the liver?
The liver is held in place by several ligaments. The most notable ones include the ligamentum teres hepatis, which is the remnant of the umbilical vein, and the ligamentum venosum, a remnant of the ductus venosus from fetal circulation. Other important ligaments are the falciform ligament, which attaches the liver to the anterior abdominal wall, and the coronary and triangular ligaments, which secure the liver to the diaphragm.
How do these ligaments contribute to liver function?
These ligaments help maintain the liver's position within the abdomen, ensuring it doesn't shift with body movements. They also contain important blood vessels and bile ducts that are essential for the liver's function.
What can you tell me about the vascular supply of the liver?
The liver has a dual blood supply, the hepatic artery and the portal vein. The hepatic artery provides oxygen-rich blood, while the portal vein brings nutrient-rich blood from the digestive organs. This dual supply is crucial for the liver's metabolic and detoxification functions.
How does the blood flow through the liver?
Blood from both the hepatic artery and portal vein enters the liver at the porta hepatis. From there, it flows through the liver's sinusoids, where it is processed by hepatocytes. The blood is then collected by the central veins of each lobule, which merge into the hepatic veins, and finally drains into the inferior vena cava.
What about the bile ducts?
The bile produced by the liver is collected by a network of bile ducts that eventually merge into the right and left hepatic ducts. These ducts join to form the common hepatic duct, which then combines with the cystic duct from the gallbladder to form the common bile duct. The bile is transported to the duodenum to aid in digestion.
Can you explain the concept of liver segments?
Sure. The liver is divided into 8 functional segments based on its vascular supply. These segments are important in surgical procedures because they allow for precise removal of diseased parts without affecting the rest of the liver. Each segment receives its own blood supply from the portal vein, hepatic artery, and bile duct.
Why is this segmentation important in surgery?
Segmentation allows surgeons to perform partial hepatectomies, removing only the affected segments. This is particularly useful in cases of tumors or other localized liver diseases. By understanding the segmental anatomy, surgeons can minimize damage to healthy liver tissue.
This has been really informative. Thank you, Emma.
You're welcome. The liver is a fascinating and complex organ, and understanding its anatomy and function is essential for both medical professionals and students.
Hello, Emma. Could you explain the biliary system to me?
Sure. The biliary system is a crucial part of the liver's function in the human body. The liver is the largest gland we have, and it produces a fluid called bile. This bile is created in liver cells and contains bile salts, bile acids, bilirubin, and cholesterol. It's quite thin and has a golden yellow color. Bile serves both as a secretion, which the body uses, and an excretion, which removes waste products.
What exactly does bile do in the body?
Bile has 2 primary roles. As a secretion, it provides bile acids necessary for the emulsification of fats, which helps in their digestion. As an excretion, it helps in getting rid of waste products like bilirubin and cholesterol by excreting them into the bile ducts.
How much bile does the liver produce daily?
The liver produces about 1 liter of bile each day. This bile is then transported out of the liver through bile ducts.
Can you describe the structure of the bile ducts?
Of course. The bile ducts are categorized into intrahepatic and extrahepatic ducts. Intrahepatic ducts are located inside the liver. They start as bile capillaries between liver cells and merge to form interlobular bile ducts, then segmental bile ducts. These segmental ducts further combine into 2 main ducts, the right and left hepatic ducts.
What happens after these ducts leave the liver?
The right and left hepatic ducts exit the liver at the porta hepatis and join to form the common hepatic duct. The extrahepatic ducts start with the common hepatic duct, which is about 3 to 5 centimeters long and travels in the hepatoduodenal ligament. An important branch, the cystic duct, leads to the gallbladder, allowing bile to flow in both directions, into and out of the gallbladder.
What happens when the common hepatic duct and cystic duct merge?
They form the common bile duct, or ductus choleticus, which is about 8 centimeters long. This duct continues to the major duodenal papilla, where it joins the pancreatic duct and empties into the duodenum.
What changes occur if the gallbladder is removed?
When the gallbladder is removed, a procedure known as cholecystectomy, the cystic duct is no longer present, and the common bile duct is referred to as the hepatocholeticus.
Can you explain the variability in the biliary system?
Yes, the biliary system can vary significantly among individuals. For example, about 60% of people have a classical anatomy of intrahepatic bile ducts. However, others might have trifurcation where the right, left, and quadrate ducts enter the common hepatic duct separately, or unique ducts for certain liver segments. This variability is important to know, especially before surgeries like gallbladder removal, to avoid accidentally tying off important bile ducts.
How do doctors visualize these ducts before surgery?
There are several methods to image the bile ducts. Endoscopic retrograde cholangiopancreatography, ERCP, and magnetic resonance cholangiopancreatography, MRCP, are common techniques used to understand the biliary anatomy before operations.
What about the extrahepatic bile ducts during surgery?
The relationships of the extrahepatic bile ducts to nearby blood vessels are very important during surgery. For example, the cystic artery, which supplies the gallbladder, must be carefully managed. There's also a known anatomical variation called Jortso's crook, where the right bile duct loops around the middle segment of the portal vein.
Are there any other important variations to consider?
Yes, the cystic duct's point of origin can vary. Sometimes it arises close to the right hepatic duct or has a deep origin, looping behind the main bile duct. Understanding these variations is crucial for surgeons to avoid complications during procedures.
Could you explain the structure and function of the gallbladder?
Certainly. The gallbladder, or vesica is a muscular and hollow organ shaped like a pear, measuring about 8 to 12 centimeters in length with a capacity of approximately 50 milliliters. It's situated in the fossa vesicae of the liver.
What are the different layers of the gallbladder?
The gallbladder is composed of several layers. 1. Tunica serosa *. This is the peritoneal covering of the gallbladder, consisting of a single layer of flat epithelial cells. 2. Tela subserosa *. This layer of connective tissue lies beneath the serosal epithelium. 3. Tunica muscularis *. The muscular layer of the gallbladder wall. 4. Tunica mucosa *. The mucous membrane of the gallbladder, covered by a single layer of columnar epithelial cells. 5. Plici-mucosae *. These are mucosal folds that create a ridged appearance.
What are the different parts of the gallbladder?
The gallbladder is divided into three main parts. 1. Fundus vesicae biliaris *. The bottom or fundus of the gallbladder. 2. Corpus vesicae biliaris *. The body of the gallbladder. 3. Column vesicae biliaris *. The neck of the gallbladder, which connects to the cystic duct.
What is the function of the cystic duct?
The cystic duct connects the gallbladder to the common bile duct. It has a spiral fold known as the plica spiralis, which allows bile to flow in both directions, but can also hinder the passage of gallstones.
How does the neck of the gallbladder function?
In the neck of the gallbladder, bile is concentrated by absorbing water. However, this can sometimes lead to the crystallization of certain elements in bile, such as cholesterol and bilirubin, forming gallstones.
What happens when gallstones form?
Gallstones, or concretions, can vary in size. Small stones may travel through the cystic duct into the duodenum and be expelled from the body. However, they can also get lodged along the way, causing intense pain known as biliary colic due to spasms of the smooth muscle. Larger stones often cannot pass through the cystic duct, leading to obstruction, gallbladder enlargement, and possibly chronic inflammation.
How is the gallbladder's blood supply managed during surgery?
During gallbladder surgery, critical structures like the cystic duct and the cystic artery must be carefully ligated. The cystic artery typically branches from the right hepatic artery. However, its origin can vary significantly, sometimes arising from the gastroduodenal artery, the celiac trunk, or the left hepatic artery. Understanding these variations is crucial to avoid mistakenly clipping other important vessels.
How does the lymphatic drainage of the gallbladder work?
The lymphatic drainage of the gallbladder follows the bile ducts and eventually reaches lymph nodes along the portal vein, including hepatic nodes, superior pyloric nodes, celiac nodes, and right cardiac nodes. These lymph nodes can be affected if there are issues with bile drainage or if there are accessory vessels running to the liver.
Thank you for listening. If our podcast has been valuable to you, we would greatly appreciate it if you could leave us a 5-star rating and write a review on Spotify and Apple Podcasts, or subscribe, like, and share on our YouTube channel. Your support helps us greatly with discoverability. We hope to see you soon.
Hello, Emma. Can you explain the skeletal structure of the thorax?
Absolutely. The thoracic skeleton is composed of the thoracic vertebrae, ribs, and sternum. This forms the thoracic cage, or thorax.
What are the main parts of the thorax?
The thorax includes the thoracic cavity, or cavitas thoracis, the superior thoracic aperture, or apertura thoracis superior, which is the upper opening of the thoracic cavity, and the inferior thoracic aperture, or apertura thoracis inferior, which is the large lower opening. The spaces between the ribs are known as intercostal spaces or spatia intercostalia.
Can you tell me more about the ribs?
Certainly. Ribs, or costae, are dorsally attached to the thoracic vertebrae. They have a thin layer of compact bone on the surface and spongy bone inside. Ribs are curved and categorized into 3 types. 1. True ribs, costae vary. These are the first 7 pairs of ribs, and they are connected to the sternum by costal cartilage. 2. False ribs, costae spurii. These are the next 3 pairs of ribs, and they are connected ventrally to the cartilage of the preceding rib. 3. Floating ribs, costae liberi or fluctuans. These are the last two pairs of ribs, lacking a cartilaginous part and embedded within the abdominal wall muscles.
What are the main features of a typical rib?
A typical rib has several key features. 1. Costa, rib, a long, slender, and curved bone. 2. Cartilage costalis *, the costal cartilage that firmly attaches the rib to the sternum or the preceding rib. 3. Caput costae *, the head of the rib that articulates with the vertebral body. 4. Facies articularis capitis costae *, the articular surface on the head of the rib. 5. Crista capitis costae *, the crest that divides the rib into two surfaces. 6. Column costae *, the neck of the rib, separating the head from the rib's body. 7. Tuberculum costae *, the tubercle that articulates with the transverse process of the vertebra. 8. Corpus costae *, the body of the rib. 9. Crista costae *, the sharp lower edge of the rib. 10. Sulcus costae *, the groove along the rib. 11. Angulus costae *, the area of the rib where it curves more sharply. 12. Facies articularis tuberculi costae *, the articular surface on the rib's tubercle.
What are some specifics about the first and second ribs?
The first rib, or costa prima, is broader, shorter, and has a single curve with a prominent tubercle. It also features the sulcus arteriae subclavii, which is a groove for the subclavian artery. The second rib, or costa secunda, is longer and includes the tuberositas musculi serrati anterioris, a rough area for the attachment of the serratus anterior muscle.
What about the sternum?
The sternum, or breastbone, is composed of three parts. 1. Manubrium sterni *, the broadest part of the sternum, featuring the incisura jugularis, a notch that borders the jugular fossa, and the paired incisura clavicularis, concave articular surfaces for the clavicles. 2. Corpus sterni *, the body of the sternum, which connects to the manubrium through cartilage or synostosis. It has incisurae costalas, notches on its sides for rib attachment. 3. Processus xiphoideus *, the xiphoid process, which is the cartilaginous or ossified lower part of the sternum.
How do the ribs articulate with the sternum?
The ribs connect to the sternum through the articulatio capitis costae, where the head of the rib fits into the costal notches, or incisurae costalas, of the sternum. This articulation allows for the movement and flexibility necessary for respiration.
Thank you for listening. If our podcast has been valuable to you, we would greatly appreciate it if you could leave us a 5-star rating and write a review on Spotify and Apple Podcasts, or subscribe, like, and share on our YouTube channel. Your support helps us greatly with discoverability. We hope to see you soon.
Hello, can you explain the bones of the upper limb to me?
Of course. The upper limb is divided into the shoulder girdle and the free upper limb. The shoulder girdle connects the limb to the axial skeleton and consists of two main bones, the scapula and the clavicle. The free upper limb includes the arm, humerus, the forearm, ulna and radius, and the hand, carpal bones, metacarpal bones, and phalanges.
Can you describe the scapula for me?
Certainly. The scapula, also known as the shoulder blade, is a flat, triangular bone located on the posterior side of the rib cage. It's a complex bone with several important features. Facies dorsalis. This is the dorsal surface of the scapula, which faces outward. Facies costalis, the costal surface, which faces the rib cage. Margins. The scapula has three margins: lateral, medial, and superior. Angles. There are three angles: superior, lateral, and inferior. Some notable structures on the scapula include spinous scapulae, a prominent ridge running across the dorsal surface, dividing it into the supraspinous fossa, above the spine, and the infraspinous fossa, below the spine. Acromion, an extension of the spine that forms the highest point of the shoulder, which articulates with the clavicle. Coracoid process, a hook-like projection that serves as an attachment site for muscles such as the pectoralis minor and the biceps brachii. Glenoid cavity, a shallow, concave structure that articulates with the head of the humerus to form the shoulder joint.
What about the clavicle?
The clavicle, or collarbone, acts as a strut between the scapula and the sternum, providing support and stability to the shoulder. Key features include sternal end. This end articulates with the manubrium of the sternum, forming the sternoclavicular joint. Acromial end. This end articulates with the acromion of the scapula, forming the acromioclavicular joint. Superior and inferior surfaces. The superior surface is smoother, while the inferior surface has ridges and grooves for muscle and ligament attachments. Anterior and posterior margins. The margins serve as attachment sites for muscles like the deltoid and trapezius. Costoclavicular ligament attachment. This is a roughened area near the sternal end for ligament attachment. Conoid tubercle, located near the acromial end. This is the attachment site for the conoid ligament, part of the coracoclavicular ligament.
Can you explain the humerus?
The humerus is the long bone of the upper arm and plays a crucial role in the function and movement of the upper limb. The proximal end of the humerus features head, a rounded, smooth structure that fits into the glenoid cavity of the scapula, forming the shoulder joint. Greater tubercle, a large, prominent area on the lateral side of the humerus, serving as an attachment site for the supraspinatus, infraspinatus, and teres minor muscles. Lesser tubercle, located on the anterior side, it's the attachment site for the subscapularis muscle. Intertubercular sulcus, bicipital groove, a groove between the greater and lesser tubercles, where the tendon of the long head of the biceps brachii runs. Anatomical neck, just below the head, it's a common site for fractures. Surgical neck, a narrow area below the tubercles, also a frequent fracture site. The shaft of the humerus has deltoid tuberosity, a roughened area on the lateral side for the attachment of the deltoid muscle. Radial groove, a shallow groove on the posterior side, accommodating the radial nerve and deep brachial artery. The distal end includes capitulum, a round, smooth structure on the lateral side that articulates with the head of the radius. Trachea, a spool-shaped structure on the medial side that articulates with the trochlear notch of the ulna. Medial and lateral epicondyles, projections on either side of the distal humerus for muscle attachment. The medial epicondyle is larger and serves as the attachment site for the flexor muscles of the forearm, while the lateral epicondyle is for the extensor muscles.
What about the radius and ulna?
The radius and ulna are the two bones of the forearm. The radius is located on the lateral side, thumb side, and the ulna is on the medial side, pinky side. Radius. Head, a disc-shaped structure that articulates with the capitulum of the humerus and the radial notch of the ulna. Neck, just below the head, providing a slight narrowing. Radial tuberosity, a roughened area on the medial side for the attachment of the biceps brachii tendon. Shaft, slightly curved with interosseous borders facing the ulna. Distal end, includes the styloid process, a bony projection on the lateral side, and the carpal articular surface, which articulates with the carpal bones to form part of the wrist joint. Ulna. Olecranon, the prominent, pointed bone at the elbow's back, forming the elbow's bony tip. Trochlear notch, a large, curved area that articulates with the trochlea of the humerus. Coronoid process, a projection on the anterior side, just below the trochlear notch. Radial notch, a small, shallow notch on the lateral side that articulates with the head of the radius. Shaft, long and slightly curved with interosseous borders facing the radius. Distal end, features the head, which is smaller than the proximal end, and the styloid process, a pointed structure for ligament attachment.
How are the bones of the hand structured?
The hand is a complex structure composed of 3 groups of bones. Carpal bones, 8 small bones arranged in 2 rows. These bones are essential for the wrist's complex movements. Proximal row, from lateral to medial scaphoid, lunate, triquetrum, and pisiform. Distal row, from lateral to medial trapezium, trapezoid, capitate, and hamate. Metacarpal bones, 5 bones forming the palm. Each metacarpal bone has a base, shaft, and head. The bases articulate with the carpal bones, and the heads articulate with the proximal phalanges of the fingers. First metacarpal, associated with the thumb and is the shortest and thickest. Second to fifth metacarpals vary in length and thickness. Phalanges, 14 bones in the fingers. Each finger has 3 phalanges, proximal, middle, and distal, except for the thumb, which has only 2, proximal and distal.
What about the joints of the upper limb?
The upper limb joints allow a wide range of movements essential for various activities. Shoulder joint, glenohumeral joint, a ball and socket joint allowing a wide range of movements, including flexion, extension, abduction, adduction, internal and external rotation, and circumduction. It's supported by several muscles, including the rotator cuff muscles, ligaments, and the labrum, a fibrocartilaginous structure that deepens the glenoid cavity. Elbow joint, a hinged joint formed by 3 articulations. Humerulnar joint, between the trochlea of the humerus and the trochlear notch of the ulna. Humeroradial joint, between the capitulum of the humerus and the head of the radius. Proximal radioulnar joint, between the head of the radius and the radial notch of the ulna, allowing pronation and supination of the forearm. Wrist joint, radiocarpal joint, formed between the distal end of the radius and the proximal row of carpal bones, except the pisiform. It allows flexion, extension, abduction, radial deviation, adduction, ulnar deviation, and circumduction. The wrist joint is supported by ligaments, including the radiocarpal ligaments and the triangular fibrocartilage complex, TFCC. Each joint is stabilized by a combination of ligaments, muscles, tendons, and other structures to provide both stability and a wide range of motion.
This is a lot of information. Can you summarize the main points?
Certainly. The upper limb consists of the shoulder, girdle, and the free upper limb. Key bones include scapula, flat bone with important features like the spine, acromion, and glenoid cavity. Clavicle, acts as a strut between the scapula and sternum. Humerus, long bone of the upper arm with distinct proximal, shaft, and distal features. Radius and ulna, bones of the forearm, with the radius on the thumb side and the ulna on the pinky side. Hand bones, comprising carpal bones, wrist, metacarpal bones, palm, and phalanges, fingers. Joints of the upper limb include the shoulder, elbow, and wrist joints, each allowing a range of movements necessary for daily activities.
Thank you. This was very informative.
You're welcome. Understanding the anatomy of the upper limb is crucial for diagnosing and treating injuries effectively. Don't hesitate to ask if you have more questions.
Thank you for listening. If our podcast has been valuable to you, we would greatly appreciate it if you could leave us a 5-star rating and write a review on Spotify and Apple Podcasts, or subscribe, like, and share on our YouTube channel. Your support helps us greatly with discoverability. We hope to see you soon.
Hi, Emma. Could you explain the basic structure of the pelvis and how it relates to the lower limbs?
Of course. The pelvis, or os coxae, is formed by the fusion of 3 bones, the ilium, ischium, and pubis. Together, these form a single pelvic bone.
All of this.
The femur, or thigh bone, is the longest and strongest bone in the body. Its head, caput femoris, articulates with the acetabulum of the pelvis, forming the hip joint. It has a neck, column femoris, and 2 major projections, the greater trochanter and the lesser trochanter, which are sites for muscle attachment. Moving downward, the femur has a shaft, corpus femoris, with distinct surfaces and ridges like the linea aspera, which serves as a site for muscle attachment. At its distal end, the femur has 2 large condyles, the medial and lateral condyles, which articulate with the tibia and patella to form the knee joint.
What about the knee joint? How does it function?
The knee joint is a complex structure formed by the femur, tibia, and patella. It's primarily a hinged joint, allowing for flexion and extension of the leg. The knee also allows some rotation when it's flexed. The menisci, which are C-shaped pieces of cartilage, act as shock absorbers between the femur and tibia, and they also help with stability. The lateral meniscus is more circular and mobile, while the medial meniscus is more fixed. Several important ligaments stabilize the knee. The most notable are the cruciate ligaments, the anterior cruciate ligament, ACL, and the posterior cruciate ligament, PCL, which prevent excessive forward and backward movement of the femur on the tibia. There are also collateral ligaments on the sides of the knee, which help prevent excessive side-to-side motion.
Got it. And the tibia and fibula, how do they contribute to the lower limb structure?
The tibia, or shin bone, is the larger of the two bones in the lower leg. It supports most of the body's weight and is located medially. Its upper end has two condyles, medial and lateral, that articulate with the femur to form the knee joint. The tibia's shaft has a sharp anterior edge, which you can feel as the front of your shin, and a distal end that forms the medial malleolus, which is the inner ankle bone. The fibula, on the other hand, is a smaller bone located laterally. It doesn't bear much weight, but provides muscle attachment sites and forms the lateral malleolus, or outer ankle. The tibia and fibula are connected by the interosseous membrane, a fibrous sheet that helps stabilize these bones and provides additional surface area for muscle attachment.
And what about the foot bones? How are they structured?
The bones of the foot are divided into three sections: the tarsal bones, metatarsal bones, and phalanges. There are 7 tarsal bones in the ankle region, the largest being the calcaneus, or heel bone, and the talus, which articulates with the tibia and fibula to form the ankle joint. The metatarsal bones form the middle part of the foot. There are 5 of them, numbered from the medial, big toe, side. They connect the tarsal bones to the phalanges, which are the bones of the toes. Each toe has 3 phalanges, except the big toe, which has 2. Additionally, the foot contains sesamoid bones, which are small, round bones embedded in tendons, particularly under the big toe, helping with weight-bearing functions.
That's interesting. What ligaments are important for maintaining foot stability?
Several ligaments are crucial for foot stability. One of the most important is the ligamentum plantar longum, which supports the arch of the foot. There's also the ligamentum bifurcatum, which stabilizes the connection between the calcaneus and the cuboid bone, forming a key structure called Chopard's joint. This joint is significant for movements like inversion and eversion of the foot. Moreover, the ankle joint, or articulatio talocroralis, is stabilized by the collateral ligaments, which include both medial and lateral ligaments. These ensure that the foot remains properly aligned with the leg during movements like walking or running.
Lastly, what about the articulations between the toes and the metatarsals?
The toes articulate with the metatarsals at the metatarsophalangeal joints. These joints allow for flexion, extension, and a bit of side-to-side movement. The ligaments here are crucial for maintaining stability, especially during walking. They include the plantar ligaments, which help stabilize the arch and prevent the toes from overextending. Between the toes themselves, you have interphalangeal joints, which allow for the bending and straightening movements of the toes. Stability here is ensured by smaller ligaments that connect the phalanges.
Thank you for listening. If our podcast has been valuable to you, we would greatly appreciate it if you could leave us a 5-star rating and write a review on Spotify and Apple Podcasts, or subscribe, like, and share on our YouTube channel. Your support helps us greatly with discoverability. We hope to see you soon.
Hi, Emma. Can you explain the structure and components of the vertebral column?
Of course. The vertebral column, or spine, is a crucial structure in the human body, composed of individual bones called vertebrae. These vertebrae are connected by ligaments, joints, and intervertebral discs, which allow for movement and flexibility while providing stability. The intervertebral discs, made of fibrocartilage, serve as shock absorbers and facilitate the spine's flexibility.
What are the different sections of the vertebral column?
The vertebral column is divided into 5 sections, each with distinct characteristics and functions. 1. Cervical vertebrae, C1, C7. These are the smallest and lightest vertebrae located in the neck. They support the skull and allow for a range of head movements. The first cervical vertebra, known as the atlas, supports the skull and allows for nodding movements. The second vertebra, the axis, has a unique structure called the dens, which acts as a pivot for the atlas, enabling head rotation. 2. Thoracic vertebrae, T1, T12. These vertebrae are larger than the cervical vertebrae and have facets for rib attachment, which provides stability to the thoracic cage and protects vital organs like the heart and lungs. Each thoracic vertebra has costal facets for rib articulation and long, downward-sloping spinous processes. 3. Lumbar vertebrae, L1, L5. These are the largest and strongest vertebrae, designed to bear much of the body's weight. They allow for significant movement and flexibility due to their large vertebral bodies, which are kidney-shaped. The lumbar vertebrae have short, stout spinous processes for muscle attachment and a triangular vertebral foramen to accommodate the lumbar enlargement of the spinal cord. 4. Sacrum, S1, S5. The sacrum consists of 5 fused vertebrae that form a triangular bone connecting the spine to the pelvis. It supports the weight of the upper body when standing and walking. The sacrum features the sacral promontory, which is the anterior projecting edge of the first sacral vertebra, and the ali, which are wing-like projections on either side. 5. Coccyx, Co1, Co4/5. The coccyx, or tailbone, is formed by the fusion of 4 to 5 vertebrae. Though it is a vestigial structure, it serves as an attachment site for various muscles, tendons, and ligaments that contribute to the function of the pelvic floor.
What are the main parts of a typical vertebra?
A typical vertebra consists of several key components. 1. Vertebral body, corpus vertebrae. This is the main weight-bearing part of the vertebra, filled with spongy bone and red marrow. It provides structural support and helps bear the body's weight. 2. Vertebral arch, arcus vertebrae. This arch forms the vertebral foramen, through which the spinal cord passes. The vertebral arch comprises the pedicles and laminae. 3. Pedicles. These are short, thick processes that project backward from the vertebral body and connect it to the laminae. 4. Laminae. These are flat plates of bone that form the posterior part of the vertebral arch, completing the vertebral foramen. 5. Processes. These include the spinous process, transverse processes, and articular processes. The spinous process projects dorsally from the junction of the laminae, the transverse processes extend laterally, and the articular processes project upward and downward to articulate with adjacent vertebrae.
Can you elaborate on the specific features of the cervical vertebrae?
Certainly. The cervical vertebrae have unique features to support their function. Atlas C1. It has no body or spinous process. Instead, it consists of an anterior and posterior arch and large lateral masses. The atlas supports the skull, allowing for nodding movements. It articulates with the occipital condyles of the skull via the superior articular surfaces. Axis C2. It features the dens, a peg-like structure that projects upward and acts as a pivot for the atlas, allowing for head rotation. The dens is secured by ligaments that prevent excessive movement. C7. Vertebra prominence. It has a long, prominent spinous process that is easily palpable through the skin. This vertebra serves as an important anatomical landmark.
What about the thoracic vertebrae?
The thoracic vertebrae are adapted to support the ribs and protect the organs of the chest. Each thoracic vertebra has costal facets. These are smooth surfaces on the vertebral body and transverse processes where the ribs attach. Long spinous processes. These processes point downward and overlap each other to some extent, providing additional stability to the thoracic spine.
And the lumbar vertebrae?
The lumbar vertebrae are robust structures designed to bear the body's weight and enable movement. They have large vertebral bodies. These are kidney-shaped and designed to support significant weight. Short, stout spinous processes. These processes provide attachment sites for the muscles of the lower back. Triangular vertebral foramen. This shape accommodates the lumbar enlargement of the spinal cord.
What is the sacrum, and what are its functions?
The sacrum is a triangular bone at the base of the spine, formed by the fusion of 5 sacral vertebrae. It connects the spine to the pelvis through the sacroiliac joints. Key features include promontory, the anterior projecting edge of the first sacral vertebra. Ali, wing-like projections on either side that articulate with the ilium of the pelvis. Foramina. These openings allow nerves and blood vessels to pass through. The sacrum provides structural support and stability to the pelvis and contributes to the formation of the pelvic cavity.
Finally, what about the coccyx?
The coccyx, or tailbone, is the terminal part of the vertebral column, composed of 4 to 5 fused vertebrae. Although vestigial, it serves as an attachment site for various muscles, tendons, and ligaments that contribute to the function of the pelvic floor. The coccyx helps to support and stabilize a person when they are sitting.
Thank you, Emma. This detailed explanation really helps in understanding the complex structure of the vertebral column.
Thank you for listening. If our podcast has been valuable to you, we would greatly appreciate it if you could leave us a 5-star rating and write a review on Spotify and Apple Podcasts, or subscribe, like, and share on our YouTube channel. Your support helps us greatly with discoverability. We hope to see you soon.
Hi, Emma. Can you explain the different muscle groups in the upper limb?
Certainly. The upper limb muscles are divided into several groups based on their location and function. Let's go through each of these groups.
Let's start with the shoulder muscles. What can you tell me about them?
The shoulder muscles, or musculi humeri, surround the shoulder joint and attach to the proximal end of the humerus. Key muscles here include the rotator cuff muscles, which are crucial for shoulder stability and movement. The rotator cuff consists of rotator cuff muscles, supraspinatus, origin, supraspinous fossa of the scapula, insertion, greater tubercle of the humerus, function, abduction of the arm at the shoulder joint, innervation, suprascapular nerve, C5, C6, infraspinatus, origin, infraspinous fossa of the scapula, insertion, greater tubercle of the humerus, function, external rotation of the arm, innervation, suprascapular nerve, C5, C6, teres minor, origin, lateral border of the scapula, insertion, greater tubercle of the humerus, function, external rotation of the arm, innervation, axillary nerve, C5, C6, subscapularis, origin, subscapular fossa of the scapula, insertion, lesser tubercle of the humerus, function, internal rotation of the arm, innervation, upper and lower subscapular nerves, C5, C6.
What about the muscles of the arm?
The muscles of the arm, or musculi brachii, can be divided into anterior and posterior groups. Anterior group. Biceps brachii. Origin. Long head, supraglenoid tubercle of the scapula. Short head, coracoid process of the scapula. Insertion, radial tuberosity and bicipital aponeurosis. Function, flexes the elbow and supinates the forearm. Innervation, musculocutaneous nerve, C5, C6. Brachialis. Origin, anterior surface of the humerus. Insertion, coronoid process and ulnar tuberosity. Function, primary flexor of the elbow. Innervation, musculocutaneous nerve, C5, C6, and radial nerve, C7. Coracobrachialis. Origin, coracoid process of the scapula. Insertion, medial surface of the humerus. Function, flexes and adducts the arm. Innervation, musculocutaneous nerve, C5, C7. Posterior group. Triceps brachii. Origin, long head, infraglenoid tubercle of the scapula. Lateral head, posterior surface of the humerus, superior to the radial groove. Medial head, posterior surface of the humerus, inferior to the radial groove. Insertion, olecranon of the ulna. Function, primary extensor of the elbow. Innervation, radial nerve, C6, C8.
Can you describe the muscles of the forearm?
The forearm muscles, or musculi antebrachii, are categorized into anterior, lateral, and posterior groups. Anterior group. Superficial layer, originates from the medial epicondyle of the humerus. Flexor carpi radialis, flexes and abducts the wrist. Palmaris longus, tenses the palmar aponeurosis and flexes the wrist. Flexor carpi ulnaris, flexes and adducts the wrist. Pronator teres, pronates the forearm. Deep layer, includes muscles that flex the fingers. Flexor digitorum superficialis, flexes the middle phalanges of the fingers. Flexor digitorum profundus, flexes the distal phalanges of the fingers. Flexor pollicis longus, flexes the thumb. Pronator quadratus, pronates the forearm. Lateral group. Brachioradialis. Origin. Lateral supracondylar ridge of the humerus. Insertion. Styloid process of the radius. Function. Flexes the elbow. Innervation. Radial nerve, C5, C6. Extensor carpi radialis longus and brevis, extend and abduct the wrist. Posterior group. Superficial layer, extends the wrist and fingers. Extensor digitorum, extends the fingers. Extensor digiti minimi, extends the little finger. Extensor carpi ulnaris, extends and adducts the wrist. Deep layer. Supinator, supinates the forearm. Abductor pollicis longus, abducts the thumb. Extensor pollicis brevis and longus, extend the thumb. Extensor indicis, extends the index finger. Innervation, radial nerve, C7, C8.
What about the muscles of the hand?
The hand muscles, or musculi manus, are responsible for fine motor movements. They are divided into thenar, hypothenar, and intermediate groups. Thenar muscles control the movements of the thumb. Abductor pollicis brevis abducts the thumb. Flexor pollicis brevis flexes the thumb. Opponens pollicis opposes the thumb. Adductor pollicis adducts the thumb. Innervation, median nerve, thenar muscles, and ulnar nerve, adductor pollicis. Hypothenar muscles control the movements of the little finger. Abductor digiti minimi abducts the little finger. Flexor digiti minimi brevis flexes the little finger. Opponens digiti minimi opposes the little finger. Innervation, ulnar nerve, C8, T1. Intermediate muscles include the lumbricals and interossei. Lumbricals, for muscles that flex the MCP joints and extend the IP joints. Origin, tendons of the flexor digitorum profundus. Insertion, extensor expansion of the fingers. Innervation, median nerve, lateral 2, and ulnar nerve, medial 2. Interossei, divided into dorsal, 4 muscles, and palmar, 3 muscles, groups. Dorsal interossei, abduct the fingers. Palmar interossei, adduct the fingers. Innervation, ulnar nerve, C8, T1.
Lastly, could you explain the anatomy of the axillary region?
The axillary region, or armpit, is a pyramidal space between the upper arm and the lateral chest wall. It serves as a passageway for nerves and vessels to the upper limb. Key structures include: the axillary region, or armpit, is a pyramidal space between the upper arm and the lateral chest wall, serving as a passageway for nerves and vessels to the upper limb. Key structures include: anterior wall, formed by the pectoralis major muscle. Posterior wall, formed by the latissimus dorsi, teres major, and subscapularis muscles. Medial wall, formed by the serratus anterior muscle along the rib cage. Lateral wall, formed by the humerus. Base, formed by the skin, subcutaneous tissue, and axillary fascia. Apex, bound by the first rib, clavicle, and superior border of the scapula. Key features: axillary artery and vein, major blood vessels supplying the upper limb. Brachial plexus, a network of nerves that innervate the upper limb. Axillary lymph nodes, important for lymphatic drainage from the upper limb and breast region. The axillary space is essential for the passage and protection of these vital structures, with each wall providing specific structural and functional support.
Thank you for listening. If our podcast has been valuable to you, we would greatly appreciate it if you could leave us a 5-star rating and write a review on Spotify and Apple Podcasts, or subscribe, like, and share on our YouTube channel. Your support helps us greatly with discoverability. We hope to see you soon.